pulposus. And if you push hard enough on anybody's nucleus pulposus, you can imagine that's going to put in an incredible amount of force through the annulus fibrosus. And over time, that can lead to degeneration and tearing of some of those fibers. And then at each end of the discs, as they line up, you can see here, the disc is sort of pancaked between two vertebral bodies. And where those vertebral bodies touch the disc, that's called the end plate. And a lot of nutrients need to get to the disc through the end plate. So that needs to be a healthy environment to help keep our disc as healthy as possible. A little bit of terminology here. When you read your MRIs, you'll see terms like internal disc disruption, okay? What this is, the inside, the annulus fibrosis starts to have little nicks or injury from pressure from the nucleus pulposus. And this creates a little bit of an area for you to have inflammatory reactions. So you start to have a breakdown, a degradation of the disc, and that leads to nociceptive, so pain fibers start to get involved. So you'll start to notice lower back pain. This pain is also from inflammatory mediators as this process occurs. And that leads to increased mechanical loading on the disc and also onto the end plate. And it starts this catabolic cascade within our discs. Now, term DDD, or degenerative disc disease, this is really a little bit as we age. It's a progressive phenomenon, and what happens is the fluid that's in the nucleus pulposus starts to dry up, and it leads to fibrosis. This leads to certain protein breakdown products, something called proteinase activation, and this decreases the intervertebral disc cell viability and leads to further reduction in what's called proteoglycan production. Proteoglycans hold on to water very tightly and allow our discs to remain with some fluid in them. So this is a process, and as we lose height in the front of the discs, as they get less fluid in them, you start to load what's called the facet joints, and I'll show you what the facet joints are. And they're like any joint, they can become arthritic and become a source of pain as we get older. Final bit of terminology is a disc herniation. That gel-like substance in the middle of our discs, if that starts to move out beyond its normal contours, we call that a disc herniation. And these occur in stages. You can have broad-based disc bulges. You can have a protrusion where it actually comes out in a certain area. And then you can have it that it actually breaks apart, and the piece of the inside material from the nucleus pulposus actually leaves, we say it leaves the mothership, and that's a sequestration. And a lot of times those sequestrated disc fragments are very hard for our body to break down so that they can become a chronic irritant if they're sitting near the nerves. These disc herniations are often a cause of radicular pain down the legs, and it can be the chemical mediators, and it can also be the pressure put on the nerve roots. So there's a couple different ways that pain can be manifested because of these changes in our discs. So again, here's the anatomy just to refresh. You have the annulus fibrosus and then the nucleus pulposus and the vertebral end plate. And again, they stack up on each other. And we can see here, as you move forward and backwards on the left side of this, you can see the facet joints, which are located in the posterior aspect of our spinal column, start to get forces put on them, and they can degenerate and become a source of pain. On the right side of this, it shows you a disc herniation going into where the nerve roots are exiting from the spinal column. And that, of course, can lead to mechanical pressure on the nerve, as well as chemical irritation as the body reacts to the inflammatory process that happens acutely. And then we also can think of other things that can be pain generators. The little muscles that control all the movements, the deepest muscles of what are called the multifidi, can become atrophied because of pain. We don't use them. As we don't use them, just like if we put a cast on our leg or our arm, the muscles going through those areas that are casted become atrophy. And our backs are the same way. If we stop moving correctly and we start having pain, we effectively are putting a cast on our back, and that leads to atrophy of those muscles. They then can become fatigued and a source of pain. The other elements that can be painful are the major ligaments that support our lower back. So on the right side here, we show all these huge ligaments that support our lower back. A lot of pressure and forces go through those, and they can be a source of pain where they insert into bones, and the ligaments themselves, if they're strained, can become a source of pain. So when we talk about low back pain treatments, we think of first non-operative. Most people have gone through a phase of this before they ever see us. But the common ones are exercise, heat, ice, physical therapy, acupuncture, oral steroids, manipulation, NSAIDs. Weight loss certainly would be up there. Other things that have been studied are Tai Chi, yoga. I mean, there's a whole host of other things that can be done. And if people are in severe pain, opioids become a management option, although in today's opioid crisis, it's largely being very much avoided for chronic non-malignant pain. Then operative, I just listed a few things here that are done. Discectomy is where they remove some of that disc that is herniated. They can do that with or without lumbar fusions. There's disc replacement surgeries. Foraminotomy means they open up where the area where the nerves exit from the spine are narrowed. They open that up. A facetectomy, that just means they remove the facet joint when they do the discectomy. And then when people have spinal stenosis, you'll hear of spacers being placed in the posterior elements. This prevents you from putting the back in a position that will narrow the canal further and can lead to some symptomatic improvement, maybe over the short term. Long-term outcomes aren't really that great, like most other surgical interventions. So then we talk about other, what we're going to talk about here is injection-based treatments. Typically, these are cortisone or steroid-based injections. The pros of steroids, well, they reduce inflammation, and they also certainly can help with the chemical irritation when local inflammatory mediators are released acutely. But the cons of them are that they really decrease the healing potential of the area. Not only do they decrease the inflammatory phase, but also the reparative phase gets blunted as well. So really you're just buying time, and usually if we don't change the way we do things, your symptoms are going to return when the steroid kind of wears off. Steroids also alter our immune function. People are more susceptible to infections around the course of getting steroids. They elevate blood sugar levels. Some of the newer ones we inject in joints don't do it quite as much. But it certainly does do that. It can also lead to something called avascular necrosis, particularly in the femoral heads. A single injection, probably not that common, but more steroids over a given lifetime, it certainly becomes something that can happen. And also, for the most part, steroids are short-based. They last a couple weeks, and then symptoms sort of return. So our goal with injection-based treatments is to try and identify in all those generators of pain in our lower back, what is the cause? And then we can successfully get medication or regenerative treatments to those areas. So if it's a facet joint, we'd like to get the medication to the facet joint. If it's a disc, we'd like to get it to the disc. If it's a muscle, we'd like to get it to a muscle. So that's what we try to do, take a careful history and then evaluate the patient, what makes their pain worse, and then come up with a treatment plan that best suits them. It's not just, oh, you had an MRI and there's a disc herniation, let's just do an injection here. You have to really look at what's causing the pain. Some definitions when we talk about regenerative treatments. You'll hear in the literature PRP, which stands for platelet-rich plasma. What we do here is we concentrate platelets to very high levels, up to 10 times over physiologic levels, and extract those from your blood, and then use those and their growth factors and inject them very, very pointedly where we see damage or where we think the pain generator is. Now, when I was in medical school, over 20 years ago, We learned that platelets just stop bleeding. They stay in the blood for 7 or 8 days, and then they have to be replenished. They don't have, you know, a nucleus. And aspirin inhibits them, you know. But now we realize that platelets are the first thing to arrive when you have injury. And on the right side of this, I show you platelets arrive, and it may be the growth factors that they release that lead to neutrophils and macrophages to come into the area and change the environment so that we can lead to collagen synthesis and wound strength and remodeling several months later. So platelets are very much in the forefront of what we're trying to do with their growth factors. And we think that the role of platelets, again, here, this is just saying some of the same things. There's over 1,500 proteins, growth factors, and cytokines and chemokines that are contained in platelets. These include things like vascular endothelial growth factor, insulin-like growth factor, tissue transforming growth factor, beta-1, platelet-derived growth factor. All of these are long, fancy words of things that are identified and have a physiologic process in doing what we want them to do, which is, you know, recruitment and proliferation and maturation of cells. So we're trying to heal things, to regenerate things like tendons, ligaments, muscles, bones, and cartilage. More definitions. Now we talk about platelets are acellular. They don't have cells in them, but they have growth factors. But then you have cells in your body called stem cells. These are, if they're from your own body, they're autologous. A classic is a mesenchymal stem cell. This is from your bone marrow. The mesoderm, when we developed, is the middle growth area of our body. You have the ectoderm on the outside and the endoderm on the inside, and then you have the mesoderm. And that's where we get mesenchymal stem cells from the bone marrow. You also have stem cells in your adipose tissue, and these, in this location, they're in the vasculature. They sit on the vasculature in the adipose tissues, and they're called pericytes. When there's injury, they peel off of the vasculature and they become full-blown stem cells. And we call these guys the repairmen of the body. They can reproduce themselves, and in certain cases, they can even remodel and become, you know, other cells more mature, like adipocytes, chondrocytes, and osteoblasts. Where do we get stem cells? Well, in the literature, it's kind of controversial. There's many sources of getting stem cells from other people or from outside sources, namely cord blood, amniotic tissue, and embryos. These, again, are allogenic from another person. There is a risk of getting infectious diseases, although very low. And again, controversial, you know, getting them from amniotic fluid or from cord blood. But again, they're from other people. In our practice, where do we get your stem cells? Well, we do usually from the posterior superior iliac spine, which is located in the pelvis. We will drill into the bone marrow there and collect our bone marrow cells. And then, you know, Americans are always excited about liposuction, and we can do adipose, we can do a lipoaspirate, and get the pericytes from your adipose tissue and use those. They're processed, they're cleansed, and they're, you know, the toxins from the adipose are removed, and then we resize them to a size that can be injected through a needle so we can get them to where they need to do their thing. So then, what is a potential for stem cells in intervertebral discs? Well, we know they decrease interleukin-1 activity. Interleukin-1 is a degradative, painful, and in very high levels as we have degeneration of our discs. So we think that it breaks down certain proteins. We also have, you know, decreased activity if you put stem cells in around. There's a decrease in what's called tumor necrosis factor alpha, which is also a stimulator of inflammation and pain. We also note that there's increased anabolic activity through transforming growth factor beta and also interleukin growth factors, among several others that are really too long to sort of discuss. So the goal when we put these stem cells into a disc would be to increase the viability of the intervertebral disc cells and maintain a healthy environment. What this leads to is increased proteoglycan synthesis, so that the fluid at the proteoglycans, they keep water around them and a lot of fluid in the discs and keep the discs healthy. And that's what will hopefully lead to decreased pain when we inject them. So I just want to go over a little bit of anatomy again, and the goal here is to get the medication or growth factors to the correct location. And how do we do that? Well, if you have spinal stenosis, which is narrowing of the spinal canal, we can bring a needle. We use X-ray guidance, and we bring a needle a couple different ways we can get into the epidural space. You know, there's a few millimeters there, and we're pretty good at getting it to the right location. We use a little bit of dye to make sure we're where we need to be when we do our injections. So you can do an interlaminar epidural injection. But you can also do it where the nerves come out from the back, which is called a transforaminal injection. So it's a little bit more lateral, and it gets medicine to the nerve root as it's leaving. And on the right side here, we see the two different locations, an interlaminar approach and a transforaminal approach. Again, trying to get to the epidural space to decrease inflammatory mediators that are there during an acute phase, and also to decrease the mechanical, the pressure that's being put on them. The final approach to do an epidural would be what's called a caudal, where you go to the sacral hiatus at the end of the sacrum. And there you inject the medication and allow it to flow up in the epidural space. This is often done with people who've had prior spinal surgery, where the anatomy to get to the epidural space with other injection techniques is a little bit more difficult. We had mentioned that the facet joints can become arthritic. So as the facet joints become more weighted, as we have disc degeneration, so the discs lose height, then the facet joints in the back start to bear more weight, and they become arthritic then. So we can inject those. We use, again, an X-ray guidance or fluoroscopy, and we bring the needle in there. We inject a small amount of dye and make sure we're in the right location, and we can inject PRP to those. Then we have major ligaments. I showed earlier a big scale. Ligaments can be a huge source of pain, both from being overstressed to micro tearing of them, to being over tight and causing joints around them to bear more stress. Particularly something like the sacroiliac joint. When the lliolumbar ligaments become more stiff, then all of a sudden the SI joint can be a source of pain. So we can inject these ligaments using, again, fluoroscopy, and putting a needle right into the ligament and allowing it to bathe the ligament with growth factors. Here's a depiction of where the sacroiliac joint is. The SI joint has a lot of forces going through it and major ligaments surrounding it as it bears the force of the whole lumbar spine going onto the sacrum and into the pelvis. So it can be a source of pain as well. Then you have these muscles in the lower back. I mentioned as we have pain and don't move our backs normally, you can have atrophy of these multifidi muscles. They're very small muscles that have a supporting structure to the lumbar spine. And if they're weak, then people can have chronic lower back pain. I often will show on an MRI, because radiologists rarely mention the multifidi muscles, but I'll point it out to patients. Once they visually see that their multifidi are atrophied, they realize that they have to start strengthening them regardless of pain. And as they become stronger, their pain gets better. And then you can do intradiscal injections. And again, there's techniques to get into the discs at all different levels. And again, dye would be used to verify that you're in there. And great care has to be taken when injecting into a disc. Mainly because the blood flow to the disc, it's largely avascular and gets nutrients by imbibation. So if you ever get introduce bacteria or anything into a disc, it'd be very difficult to stop that from multiplying. So you have to use excellent technique when you're getting into these regions. And I don't want to get into too much more. I want to leave time for questions, but hopefully that gives you a little overview of how we approach things and try to systematically come up with what we think would be the best solution for patients coming in with chronic lower back pain.
Okay, thanks, Dr. Agesen. So I will be answering or giving you a few questions here to answer. We had quite a few questions come through. First question is, if everyone's spine begins to degenerate after a certain age, why do some people experience pain and others do not?
That's a wonderful question, obviously. It often puzzles me when I have patients come in and I see, well, a pretty advanced degenerative process in one individual and they have relatively little pain. And then you have someone who has really normal looking imaging studies and they have horrific pain. And I think there are people who have higher levels of what we call chemotactic agents or inflammatory agents that cause pain. And those are people, if you look at people who have, let's say, rheumatoid arthritis, here you have an inflammatory autoimmune disorder that leads to chronic inflammation in areas. So here you have people who will have a lot of chemical mediators that will cause pain, and they'll have soreness and stiffness, much out of proportion to other people in society. And I think that all individuals have a certain amount of reaction to everyday activities, and some will create more inflammatory mediators. So they'll have just little chemicals that are more inflammatory. Another example would be something like gout. People who have gout, they metabolize certain proteins irregularly, and that leads to crystals in their joints. That's incredibly painful. So I think why certain people have pain is going to be maybe down the road figured out. But I think at this point, we just know some people can age quite gracefully, and other people, it's quite painful.
All right, so the next question is, does an MRI really identify where the source of pain is from?
Sometimes. And I say that because we have very many people who have, a very obvious pathology that's causing their symptoms. It's very rare that someone will come in, as a 22-year-old and say, I lifted a refrigerator and my back hurts and it's radiating down my leg, and you do an MRI and they have a disc herniation at the exact level that correlates with their pain. That's a rarity, though. Most people come into our office usually in their third or fourth decade. They've had a lot of things that they've done in their lives. So there's a lot of different things on their MRI, and they often get 1 or 2 pages of things notifying this little thing's off and this is out here and that's here. So it doesn't really give you the full picture. You need to take a very careful history, find out what the character of the pain is, what exacerbates the pain, what makes it better, and then correlate that with what you think the MRI should show. And if the MRI shows what you think it is, then I think you can say the MRI is helping you in the right direction. But if we took 15 MRIs of people who you don't have a history and you don't know what's causing their pain, the MRI is rarely going to lead you to the correct diagnosis.
Okay, so that leads us to the next question. I believe you pretty much answered it, but the question is, what percentage of population has herniated discs without symptoms?
I don't have an exact percentage. I would say that, we have a lot of discs in our back. So I think there's a lot of disc herniations that are asymptomatic. I can tell you that people who have disc herniations and radicular pain, they can have pain for 6 months and then it often kind of goes away. And if we re-image them, usually the disc herniation is still there. So they've, somehow adapted and they're living with their new anatomy. And there's also, other people who have, mostly younger people who have very large disc herniations and a very robust inflammatory response. They occasionally you repeat their MRI a year or two later, and their body has remodeled that disc, and it no longer looks like it's herniated. But I think there's very large percentage of people probably have disc herniations and are asymptomatic.
Okay, and somebody asked if you're familiar with Dr. Serrano.
Is it Sarno?
Sarano.
Yes. Dr. Sarno, he passed away. He was in New York City, and he was a regenerative medicine, not regenerative medicine, but he was a PM&R guy, I believe, like myself. And he had a very big following of patients that he was very into the psychosocial dynamic of pain. And his feeling was that a lot of chronic lower back pain was actually related to many of our own internal difficulties dealing with things in our lives. So, not to put it flippantly, but he would say, the reason you have low back pain is because you have unresolved issues with your father from when you were growing up. And, people would often look at him and be like, that's crazy. How can you say that? But if you look at his population of patients, I would say he was right on in a lot of them. And I've had many patients over the years who they'll come into me and they'll have a particularly bad few months, and they're saying, what should I do? How can I get through this? And they want me to do more injections on them, but I don't see a whole lot of things that I, quote, would say need injecting. And then a couple months later, lo and behold, they come into the office and they go, oh, Dr. Agesen, my back pain got better. I said, well, what's changed? And he said, something? For the last year, I've been getting ready to sell my business, and I didn't know what direction things were going to go. I didn't know what was going to happen to the people that worked for me, whether things would close or whatnot. But everything worked out fine, and everything settled down, and my back pain went away. So there is this stress reaction in our bodies that we don't quite understand. And I think when patients themselves realize that there is a connection between our emotional state and our underlying feeling about things, that's a huge plus in healing someone's back pain, or allowing them to deal with what's, not, pain can be protective. If you have a broken leg, you don't want to walk more on a broken leg. That's protected. You stay off it. But a lot of chronic lower back pain it's there, but we have to live our lives in spite of it. It's not dangerous. We're not causing more damage, so to speak.
Okay. All right. So next question is, does Prolozone help discs expand?
Prolozone help discs expand. So just a little background. Prolozone is the use of a gas called ozone, along with some growth factors pre-injected. And that ozone creates a reaction in our bodies that promotes our bodies to heal a little bit better. Sort of optimizes the function of our cells for a period of time, and we hope that that would lead to improvement and regeneration. I don't think there's any studies that would show that Prolozone has increased the disc heights in individuals. We do use it in the epidural space. We do use it in the muscles around the lower back and the ligaments and tendons in the lower back to stimulate a healing response. And if the muscles perform better, could you have some improvement in function in the discs? Probably. You certainly can have an improvement in pain. And Prolozone usually takes a few sessions of treatment. So it's not a one time and done. It's usually a couple treatment sessions.
Okay, if you already had an epidural injection recently in the spine, are you still a candidate for PRP?
Certainly. We like people to have a washout period of generally 4 to 6 weeks before we would do a regenerative procedure, mainly because we think the the anti-inflammatory effects of the steroid would hinder the anabolic response that we're trying to create. So, if we can wait a couple of weeks, I think that theoretically makes sense, and that's what we recommend.
Okay, and what is your opinion on disc seal?
Disc seal. I do not know disc seal, so I would need to do a little research on my own for disc seal.
Okay. Are there special considerations for using these techniques at the cervical spine level?
Could you repeat that?
Are there special considerations for using these types of regenerative techniques at the cervical spine level?
Yes, there are. I do cervical epidurals, and I do cervical facet joints, and also do some injections into the the multifidi or the paraspinal muscles in the cervical spine as well. I do not do transforaminal epidurals in the cervical spine. There is a doctor that we work with who does that, so we refer things to him when we need that. And also any disc procedures in the cervical spine would also be referred to him. There certainly are a lot of major blood vessels going through the neck and the cervical region. You have your esophagus, you have your trachea, you have some major nerves, and you also have, the major part of your spinal cord is still running through the cervical spine. In the lumbar spine, many of the injections, the spinal cord ends around L1, L2, and so what's left is called the cauda equina, which are just peripheral nerve roots. It's not a spinal cord still. So it's a much more forgiving area to inject in. So yeah, the cervical spine is definitely an area you want to, plan out your approach and use extreme caution.
Okay, and can spinal injections replace the need for back surgery, or will it complement surgery before or after to reduce pain and promote healing?
I think the back surgery is not a failure in our country. I think there's just too much of it going on. You have a lot of spine surgeons, and spine surgeons need to do what they do best, which is spine surgery. So I think they're doing the best that they can. But I think a lot of the treatments, including certain fusion techniques and whatnot, down the road a few years, we find out that they're not doing as well as we thought they would. So then we come up with different approaches to try and do things from a surgical standpoint. Certainly, regenerative treatments combined with surgical treatments, that's been going on for at least since the 1980s, when heart surgeons used to use PRP to help wound closures when they did cardiac surgery. It's been used, in the dental industry for implants and healing for that amount of time as well. So to enhance healing from a surgical standpoint, certainly I think it has a place. And I do think that down the road, maybe a certain procedure done surgically and then a regenerative procedure would make perfect sense. So I think they can work hand in hand. I don't think one would replace the other. But I do think there's many things that are treated surgically now that can be treated with regenerative medicine first, to try to avoid going for the surgery in the first place.
Okay, and somebody asked if it's true that after herniating a disc in your spine, what's called a domino effect, meaning that the other disc will then begin to take load, and this will lead to other problems down the road, such as stenosis, spondy, etc. If this is the case, why not immediately inject the disc with something like PRP to stop this domino effect?
That's it. It's reasonable to think that if you have a disc herniation, that that may progress to other areas. But I don't think that's generally the case. I think when you lose motion at a certain segment, and by that I mean, we do know from the surgical literature, if you fuse one level in the spine, that then the areas of lost motion have to be made up somewhere. And that's going to be above and below where you did the fusion. So we do see premature degeneration of those discs above and below a fused segment. But as far as a single level disc herniation leading to further areas down the road, I wouldn't say that that's necessarily true.
Okay, and can our stem cell therapies be used for a 74-year-old patient with ankylosing spondylitis that is taking Taltz for this condition? Does Medicare pay for our course of therapy?
So somebody with lumbar spinal stenosis and ankylosing spondylitis?
Yes, it says 74-year-old patient with ankylosing spondylitis.
Okay. Yeah, ankylosing spondylitis is an autoimmune disease. It tends to be progressive. Usually, if you have an astute physician, you can generally try to diagnose it in someone's late 20s, early 30s. But it often takes longer to diagnose this. There's an association with HLA-B27 haplotype, which is a certain blood marker. And generally, the treatment, it's a painful condition that leads to anesthesiopathy. So where certain major ligaments insert, there's pain and sort of a subtle inflammatory response. And it's autoimmune, so it tends to respond to some of the medications that alter the immune response, used often for rheumatoid arthritis and other autoimmune processes. So things like Humira and medications like that, which are infusion-based. There's no reason to think that putting regenerative, putting growth factors near an area with someone with with ankylosing spondylitis, that it wouldn't work. Certainly with platelet-rich plasma, PRP, we don't really have the age change that we see associated with mesenchymal stem cells from the bone marrow. We do know that bone marrow counts drop as we get older. So if you compare a 19-year-old to a 29-year-old to a 49-year-old to a 69-year-old, the 19-year-old will always seem to have more mesenchymal stem cells when we do a bone marrow draw compared to a 69-year-old. Now, having said that, I've had patients in their 70s and 80s who we've had wonderful bone marrow counts when we've done a bone marrow for knee arthritis or something like that. But generally, there is a drop-off in bone marrow mesenchymal stem cells. So that's a consideration when we're doing bone marrow. But for growth factors like PRP, we're deriving the platelets, and I think platelet counts, I think, remain stable in most people throughout their life. There can be some fluctuation, but that's not as big a consideration as when we're considering a bone marrow procedure.
Okay, and someone wrote in that's a current patient that says, "Hi, you have given me 2 ozone injections so far, and it has helped me a lot. How different is it from stem cells or platelets?"
Tremendously different. Ozone is a gas, so we have an ozone generator in our office. So when we do ozone injections, we're often injecting around the arthritic joint, and then we'll inject into the arthritic joint. And it's the ozone reacting with our body's own cells to stimulate them. And but it's not a delivery of growth factors. It's not a cellular, we don't inject cells, it's a gas we're injecting. Whereas a stem cell procedure, we're actually extracting stem cells from one area of your body, concentrating them and getting them in an injectable form and putting them in high concentrations to another area. So they're totally different, and there's often growth factors with the stem cells that we inject just by the nature of processing. So it's a vastly different way of treating things. Ozone really decreases the inflammatory response in the joint and leads to, an improvement in function, but it's not growth factors or cells.
Okay, and can a herniated disc heal? Meaning, can it like seal itself or heal by itself?
Yeah, there are people who remain having a disc herniation and they become asymptomatic, and you reimage them and they have it. But there certainly are reports in the literature. There are cells within the nucleus pulposus and in the annulus fibrosus that can repair things and can improve the internal environment and heal them. So I think if people have a disc herniation and they're told, 2 years later when they had an MRI that it went away, or that it's no longer seen, I think that's definitely possible, and I think there is the possibility of healing a disc, for sure. I think it's possible, but I think most people wind up having residual defects that sort of scar over.
Okay, and the next question is, are you familiar with Dr. Lutz's PRP intradiscal injections? He recently said that he was able to increase the PRP concentration to 15 times. In your presentation, you mentioned that the maximum is 10 times the concentration of PRP. What is your opinion on this procedure, and is it safe?
It certainly should be safe, as far as, concentrating, platelets to 15 times physiologic. I'm sure if we spun down several times, you could increase to higher concentrations and reconstitute it. I would say generally we get, up to 7 to 10 to 12 times. I am familiar with Dr. Lutz. He performs, things in the city, in New York City. And when I trained at Cornell, New York Hospital, we used to go up to his office and train with him. He's an excellent injectionist, has a lot of literature out there on what we do, and has done lots of studies on other treatments, including something called IDET, intradiscal electrocautery therapy, which is currently not supported by the literature because it didn't hold up over time. But I think it would be safe to inject 15 times physiologic growth factor, platelets. And he has a lot of, research on intradiscal treatments. That's for sure.
Okay, and let's see. Someone asked if you are still associated with Dr. Fox in Tom's River, and I believe you are, Dr. Agesen.
I am. Yeah. I work with Dr. Fox, who's he's an orthopedist down in Tom's River. He's been down there for probably 30 years. And he was interested in the stuff that we were doing and the non-operative approach that we had. And I've been going there now for 3 years. I go there on Thursdays and work with him. And it's been wonderful seeing how a surgeon approaches things and how I approach things and how we see things differently. But he's very open to seeing that regenerative procedures are sort of maybe the future. And that's why he kind of grabbed onto us and said, you guys have to come down here and bring this to central New Jersey, So we do.
Okay, and what percentage of people feel relief from PRP?
We'd have to look at our data biologics. Right? We have all patients that we do procedures on, we have something called data biologics, and it'll be a little download to your phone, and we'll contact you 3 months, 6 months, 12 months, 15 months, all the way out to try and get how people are responding to it. I would say, picking the right patients, we have a home run with our procedures. When you're taking people who've had some chronic issues, I think we have response. I think we have improvement. I think it's extremely rare that we take on a patient and they say, it did absolutely nothing. It didn't help me at all. I think that's rare. And maybe people are polite and they won't say it to our face. But my experience is that if we have the right pathology and the right patient, we do very well. I would say maybe 70 to 80% of people will improve.
Okay, and let's see, you already answered the Medicare question. So are there limits to the use of regenerative methods after a fusion?
Um, I think again, it's coming up with what we think the pain generator is and what's causing the pain. If someone's fused, the fusion itself doesn't prohibit us from doing a regenerative procedure. So I think I have plenty of people who've had prior back surgeries and we're doing regenerative procedures, mainly because they maybe didn't have the outcome they wanted. And they're looking for, they're certainly not looking for more surgery, but they remain in pain. So we're trying to find out what is the pain generator and then get what we can to heal that or improve the function of that area.
Okay, and are regenerative treatments like this good for chronic sciatica?
Uh, Again, the cause of the chronic sciatica needs to be sort of figured out. If it's from a spinal column that's very narrowed and someone has critical spinal stenosis in a region, that may be difficult. We can maybe have a temporizing effect, maybe cause some of the chemical irritants that are associated with chronic inflammation. We can certainly address those, but to say that we can open up the canal with a regenerative procedure, we can't really do that. If it's from, inflamed facet joints that are pushing on the nerve, well, certainly you can uninflame a facet joint. If it's a chronic, if it's a disc herniation that's irritating the nerve root, you certainly can get it unirritated, but then you need to supplement that with moving in the right directions or strengthening the right muscles that are allowing it to keep occurring. So when people have chronic sciatica, it's really, we got to find out what the underlying cause. If it's fibrosis from a prior surgery, that's difficult to treat. Well, we have had reductions in pain following a regenerative procedure in people who have, fibrosis around their nerve roots from a prior surgery.
Okay, and what are the potential complications of drawing bone marrow from the iliac crest?
So we go to a part of the iliac crest, kind of the medial portion of the iliac crest called the posterior superior iliac spine. And we use fluoroscopic guidance. And so that allows us to really pinpoint exactly where we're going. And we know from years of experience that the first 10 cc's of draw that we take from a specific area gives you nucleated cells. A certain percentage of those are going to be stem cells. So we drill into 4 different areas when we're doing it in the posterior superior iliac spine, and take 10 cc's from each area, and we found that that increases our numbers of nucleated cells tremendously, rather than just going to one site and taking a full 60 cc's of blood. We have not had, thank God, cross our fingers, we have not had any complications using our method. We've had no infections in 10 years of doing it. From a pain standpoint, as long as we take our time, everyone's definitely afraid of getting bone marrow. If you really take your time, and I use usually about 17 cc's of dilute lidocaine from the skin all the way down to the periosteum. And if you allow, several minutes for that to anesthetize the area, the only pain associated with it is when you actually create the negative pressure to draw the cells out. People feel sort of a non-localized pain. And for each patient, it's different. Some people, it's a little painful, and other people say, oh, it's not as bad. I don't know why I lost sleep. But it's very safe, it's very controlled, and we use a drill rather than any hammer or our hand-driven device. So it's been very safe in our hands over the years.
Okay, the next question is, can you create an environment so that the disc can heal?
I think the current literature that's out there to date is showing both in animal models and in and in human follow-up studies that there is improvement in people who have degenerative disc disease in the right settings. They've had increased disc heights, which we would assume would be increased proteoglycan and increased fluid in the discs that were previously degenerated. So I think there is an environment that's being created that's more favorable for the discs that have been injected, but it's going to take time to see exactly how everything pans out.
Okay, and once you get an intradiscal PRP injection, how long does the relief last? And do patients need to get a repeat injection? If so, how often? And does the injection result in an increase of disc height?
We, in our office at this point, wouldn't guarantee that there would be an increase in disc height. I think over periods of time with outcome studies that are currently out there, I think people are generally having improvement. People are out now maybe 24 months, so you're talking 2 years, having improvement in pain. So as the group of people getting procedures goes out longer and longer, we will have more information on how long and if they need to be repeated. At this point, I don't think we have a timeline that says, oh, in 6 months you have to have another rejection. We're not at that point. We do an injection and then we follow and we see how people are doing.
Okay, and let's see. Can an injection help spondylolisthesis of L4, L5?
Okay, so spondylolisthesis, that is a real fancy word, but if we break it down, it just means slipped bone, slipped backbone. So it's kind of like Tarzan language. So it's spondy, which means bone, and then listhesis, to slip or slide. So it's when two bones in the lower back slip in relation to each other. Now, because the bones in the lower back are sort of a jigsaw puzzle, when they slip in relation to each other, and at L4-5, it's usually a degenerative slip. It's not a congenital anomaly in the shape of the bones. So when it happens at that, there usually is some destruction or some change in the disc that's at that level. And there's usually some changes in the posterior elements that slide with the upper bone that slips. So as that slips, it pulls the posterior elements with it, and that leads to narrowing where the nerves are running and sometimes where the nerves are exiting. So those can cause irritation at multiple sites and cause pain generators at multiple sites. So you can have pain from the disc that's changing, you can have pain from the pressure in the facet joints, and you can have pain at the nerves as they exit. So each person who has a spondylolisthesis, you need to take a careful history and find out what makes their pain, exacerbates their pain, and then you can address where you would like to place your injection and what your goals would be with that injection.
Okay, and the last question here is, does a herniated disc ever heal? Someone has been dealing with this problem for 9 years.
Again, I think I think discs can heal. I think discs can become asymptomatic and remain sort of looking abnormally on an MRI. So I don't think it should take 9 years to heal a disc. So I think, if it's truly discogenic pain, which when you look at chronic lower back pain, probably, most people would say probably over 50% of it is going to be discogenic, which means that there have been changes in that disc. Most notably, often what happens when you have a cleft or a disc herniation, sensory nerves in the area get upregulated. So now you have an excess of nerves that can send sensation back, and that's an irritation. So they're nerves that it becomes pain that's often meaningless. So people then get crippled by pain that's not helping them in any way to protect them. So often, if somebody has pain that long, they've learned to move abnormally, they've learned to use muscles abnormally, and the disc herniation may be the original abnormality, but they've adapted in a maladaptive way. So often this is, again, getting back to sort of the basics of taking a history and finding out what correlates and what makes the pain worse or better, and then coming up almost with a whole new thought process. And that's again, that goes back to looking at someone like John Sarno, who would say, no disc herniation should hurt anybody for 9 years. So there's got to be some underlying cause that's not sort of mechanical or chemical. It's something else that's manifesting as that's the weak link. That would be his approach. But I would say there's often maladaptive behaviors, and that's led to the pain to last that long.
Okay, so that's the end of our questions. I want to thank everybody for attending. If you do think of any additional questions after this webinar has ended, you can give us a call at the number that you see on the screen, or you can shoot me an email at Rachel, RACHEL, at njsportsmedicine.com. So either way, we can get you an answer whether you call or email. And thank you again, everybody, for attending. Thank you, Dr. Agesen, for a great lecture.
It was a lot of fun. Thank you so much.